Okay, so let's get into this. Imagine you notice something, maybe like a bit of irritated skin,
Hmm.
dry, maybe red, flaky. The kind of thing you'd probably just think, oh, it's eczema, right?
Yeah, easily dismissed as something simple.
Exactly. But what if that little patch, and specifically if it's on the nipple, what if that's actually a sign of cancer?
That's the hook, isn't it? That kind of medical mystery. That's what we're diving into today. Mammary Paget's disease?
Right, Mammary Paget's disease of the nipple. It sounds, well, quite specific. And it really highlights why paying attention is so crucial.
It absolutely does. Even seemingly minor changes.
So we've got these revision notes here focused specifically on this condition. Our plan is to basically unpack them for you.
Yeah, turn them into a really clear, high-yield guide. Hit all the key points you need to know from these notes.
Think of it as us doing the heavy lifting, pulling out the core facts about this diagnosis, which can be, well, easily misunderstood.
Exactly. These notes are designed for focused study, straight to the point. So
Yeah.
we'll walk through them, explain the what, the why, the how,
Make it stick.
hopefully.
Okay, settle in. We're going to guide you through this. Let's turn these notes into real understanding.
All right, so section 1 from the notes, the definition. What exactly is Mammary Paget's disease?
Let's start there.
The notes define it, first off, as a rare breast cancer. But here's the interesting part. It mainly affects the skin.
The skin, not like a typical lump deep inside.
Primarily, yeah. The skin of the nipple and the areola, that darker area around it.
Okay, so it's on the surface. What makes it cancer then?
It's the presence of specific abnormal cancer cells. The notes call them Paget cells. They're found right there in the epidermis of the nipple.
Paget cells. Got it. In the nipple skin. But you said it's a breast cancer, so is it just the skin or?
Ah, good question. And this is a critical point in the notes. It's almost always linked to an underlying cancer deeper in the breast.
Always, or nearly always.
Well, the notes say often associated, but the link is very, very strong. It's usually either an invasive carcinoma,
Meaning it spread a bit.
yeah, spread beyond the ducts or lobules,
Mm-hmm.
or, more commonly, it's linked to ductal carcinoma in situ, DCIS.
DCIS, can we just quickly clarify that? DCIS means?
Sure, ductal carcinoma in situ. In situ means in its original place. So these are cancer cells, but they're still contained within the milk ducts. They haven't broken out into the surrounding breast tissue yet.
Okay. Confined cancer cells in the ducts?
Right. And the notes specify that with Paget's disease, this underlying DCIS is often located very close to the areola.
So the skin thing we see on the nipple is like a signal flare for something happening deeper inside, potentially, like cancer cells migrating outwards?
That's one of the main theories, yes.
Yeah.
The notes actually describe it quite technically as a rare cutaneous intraepithelial malignancy featuring large adenocarcinoma cells.
Okay, let's break that down. Cutaneous intraepithelial.
Means cancer within the epithelium, the top layers of the skin.
Right, and adenocarcinoma cells.
Those are the Paget cells we mentioned. They're a type of cancer cell that arises from glandular tissue, like milk ducts. So cancer cells in the nipple skin, almost always tied to cancer, often DCIS, deeper in the breast ducts.
Okay, that definition feels clearer now.
Yeah.
Rare skin cancer of the nipple areola, Paget cells involved, strongly linked to underlying breast cancer, often DCIS. Now, what about the cause, the etiology?
Yeah, the notes are pretty blunt here. The exact cause, unknown.
Still a bit fuzzy on the why, then.
For the absolute root cause, yes. But, like we said, that strong association with underlying breast cancer is key. The theory is that the Paget cells actually start in that underlying ductal cancer, either DCIS or invasive,
Uh-huh.
and then they migrate up along the milk ducts to the surface, to the nipple skin.
Ah, okay, so the skin issue is a consequence of the deeper issue. That makes sense. Who tends to be more at risk? What do the notes say about risk factors?
They line up pretty well with general breast cancer risk factors. Advanced age is a big one. It mostly affects people over 50, and obviously being female, as it's a breast cancer. Though the notes are careful to mention it can happen in men, although it's very rare.
Okay, older women predominantly, but not exclusively. What else?
Family history of breast cancer is listed. Specific genetic mutations too, BRCA1 and BRCA2 are mentioned by name.
Right, the known breast cancer genes.
Yeah. Also, hormonal factors can play a role, and having a prior history of breast cancer yourself, or even previous breast surgeries.
So the usual suspects for breast cancer risks seem relevant here too. Reinforces that connection to underlying breast disease.
Definitely.
So we have this link. How does it actually happen? The pathophysiology. How do those Paget cells cause the skin changes?
Well, the notes explain it as an infiltration process. These malignant Paget cells move into the nipple and areola skin.
Like invaders.
Sort of, yeah. They essentially push out and replace the normal cells in the epidermis, that outermost skin layer.
Okay.
And it's this replacement, this infiltration, that leads to the physical changes. You see the redness, the scaling, the thickening, all those symptoms.
Right, the cells themselves disrupt the normal skin structure. Okay. What about how common this is? Epidemiology. We know it's rare.
Very rare. The notes put it at less than 5% of all breast cancers.
Less than 5%. That's not many.
No. The incidence rate given is about 1 to 4 cases for every 1,000 breast cancers diagnosed. So really quite uncommon.
And the demographics match the risk factors, mainly women over 50.
Predominantly, yes. But the notes stress again, it could occur at any age, and don't forget the rare cases in men.
Okay, definition, risks, how it develops, how rare it is. Check. Now, the really practical bit. What does it actually look like? The clinical features?
This is where it gets tricky, clinically speaking, because it looks like other things.
Yeah.
The common signs listed are itching, redness, erythema, scaling, crusting, flaking, all on the nipple and areola.
Sounds exactly like eczema or dermatitis.
Precisely. The notes explicitly say it often looks like eczema. It can also look more severe, like an ulcerated area.
An open sore.
Yeah. Other signs mentioned are nipple discharge, and that might include bleeding, which is always a worry sign.
Definitely.
You might also see ulceration, erosions on the skin surface. Sometimes the nipple can become inverted, kind of pulled inwards.
Wow, so quite a range from just looking irritated to, well, quite alarming changes.
Yes. And here's a really crucial point from the notes. You might also find a palpable breast lump.
A lump you can feel.
Exactly. And if a lump is present along with these nipple changes, the notes say this often indicates that the underlying cancer is invasive.
Ah, okay. So skin signs are the flag, but a lump suggests it's potentially more serious underneath. Important distinction. Is it usually one side?
Typically unilateral, yes.
Yeah.
Just one nipple, though very rarely it can be bilateral. And again, the typical patient profile is a woman over 50.
Given that it looks so much like eczema, the differential diagnosis section must be key. What else could it be mistaken for?
Hugely important. The notes hammer this home because it mimics other skin issues, especially eczema.
So if you see what looks like stubborn nipple eczema, you can't just assume.
Absolutely not. And the notes give this incredibly important takeaway, like a clinical pearl. Always consider Mammary Paget's disease first when you see eczema-like changes on the nipple or areola. Rule it out before settling on an eczema diagnosis.
Wow, okay. That's a massive point. Nipple eczema equals think Paget's first. That should stick. Any other conditions in the differential?
The notes mention melanoma of the nipple, which is also serious, and something called nipple adenoma, which is benign. But the main thing is distinguishing it from simple eczema.
Right. The potential for missing a cancer by calling it eczema is the big danger. So if you suspect Paget's based on this, how do you confirm it? Investigations.
The number one step, the definitive test, according to the notes, is a skin biopsy.
Taking a small sample of the nipple skin?
Exactly. You need to get a sample of that affected skin and look at it under the microscope to see if those characteristic Paget cells are present. That confirms the diagnosis of Paget's disease itself.
Okay, biopsy confirms Paget cells. What about checking for the underlying cancer we keep talking about?
Right. So if there's a palpable lump that needs investigating separately, imaging, maybe its own biopsy to see what it is.
Yeah.
But even if there's no lump,
Yeah.
the notes stress you still need imaging, usually mammography or sometimes an MRI.
Why image if you can't feel anything?
To look for that hidden underlying cancer, particularly DCIS, which often doesn't form a distinct lump but will show up on a mammogram or MRI, it's about assessing the whole breast tissue underneath.
Okay, so biopsy the skin for Paget cells, image the breast for underlying cancer, lump or no lump. Seems like a clear diagnostic path. Once it's confirmed, how is it treated? Management.
The notes say it's generally a combination approach. Surgery plus other adjuvant therapies.
What kind of surgery? Is it always mastectomy?
That used to be the standard, sometimes with lymph node removal too, but the notes mention that breast-conserving surgery is now an option more often.
Oh, really? Like a lumpectomy equivalent?
Sort of.
Yeah.
Especially if the disease is localized just to the nipple area and there's no lump, or maybe only DCIS underneath. The notes even reference NICE guidelines supporting this in some cases.
That's good news. More tailored options. What about the adjuvant therapies? Chemo, radiation.
Yes, things like chemotherapy, radiation therapy, hormone therapy. But the key is these are based on the specifics of the underlying breast cancer, its stage, its characteristics, how far it might have spread.
Right. The treatment really depends on the whole picture, not just the skin changes. Makes sense. Lastly, prognosis and complications. What's the outlook?
Unsurprisingly, it really hinges on that underlying breast cancer. If it's caught early, especially if it's just Pagets with underlying DCIS,
Yeah,
the prognosis is generally pretty good with the right treatment. Favorable outcomes.
but if it's linked to invasive cancer,
Then the prognosis is less favorable, especially if it's spread to lymph nodes or elsewhere. And remember that point about diagnostic delay.
yes, the average delay, 12 months for women, 8 or 9 for men.
Exactly. That delay is a major challenge highlighted in the notes. It likely contributes to why the overall prognosis for Pagets is stated as generally not as good as for some more common types of breast cancer.
Because it might be caught at a later stage due to being mistaken for eczema for so long.
And that seems to be the implication. And there's that very stark note about the prognosis in men being particularly poor, a 20–30% 5-year survival rate mentioned.
Wow, that's grim. Really emphasizes the need for awareness, especially in men where breast issues are less expected. What about complications after treatment?
The notes list things like local recurrence, the disease coming back in the breast or skin, metastasis spread to lymph nodes or distant organs. There's also a risk of developing a completely new second primary cancer.
And the psychological side.
Yes, absolutely mentioned. The psychological and emotional impact on quality of life is listed as a significant complication too, dealing with the diagnosis, the treatment, the uncertainty. It all takes a toll.
Understandable. Okay, let's boil this all down. The absolute highest yield takeaways from these notes for Mammary Paget's disease.
Right. Number 1, it looks like eczema on the nipple areola, but it is cancer involving Paget cells in the skin.
Number 2, crucial link almost always associated with underlying breast cancer, usually DCIS or invasive cancer.
Number 3, investigation skin biopsy is essential to find Paget cells. Imaging, mammogram MRI, is vital to check for the underlying cancer.
Number 4, the differential diagnosis rule. Always suspect Pagets with nipple eczema first. Rule it out.
And number 5, prognosis depends heavily on the underlying cancer stage. Delay in diagnosis is common and affects outcomes negatively. Prognosis generally not as good as other common breast cancers.
That really distills it down, covers the essentials from these notes.
Yeah, hopefully hits the key points for understanding and revision.
Thinking about that diagnostic delay again, how something looking so benign can mask something serious. It prompts a final thought, doesn't it? What other, maybe subtle things might we dismiss in daily health that could actually be significant?
It's a really important point. It underlines the need to investigate persistent or unusual changes properly, especially in sensitive areas, and not just assume the simplest explanation is always the right one. Be vigilant.
Couldn't agree more. Well, that was our deep dive into Mammary Paget's disease of the nipple, pulling directly from these revision notes.
Hope breaking it down like this definition: risks, features, diagnosis, treatment, outlook, helps make those critical facts stick.
Remember, staying informed, whether you're studying for exams or just want to be aware, is so important. Knowledge is power, as they say.
Absolutely. And if you are revising and found this useful and want more resources like these notes, check out pathomsra.com.
And freemsra.com as well for more resources.
That's right.
Thanks for joining us for this deep dive.